Hello, and thank you for joining us today for the session on venous leg ulcers and how we can best manage venous leg ulcers. This is a bite-sized education module which is endorsed by the Tissue Viability Society. And really, I'm hoping today's session will be able to help with your day-to-day practice and how you look after those patients with venous leg ulcers. The content that we'll be covering today is looking at the impact that venous leg ulcers have, the difference between venous leg ulcer, arterial leg ulcer, and mixed etiology ulcers. We'll look at definitions of what that actually means, the underlying venous disease and structures that affects, the principles and types of compression that you may use, and skin preparation and treatments, ulcer assessment and how we can incorporate a simplified approach to assessment, and different options for wound management. So I'm hoping that you'll be able to take something from today's session that you'll find beneficial to your day-to-day practice. So some of the learning objectives and things that you should be able to do after this session is to be able to describe the impact that globally that leg ulcers can have, as well as the impact on an individual patient or service. Explain the vascular anatomy and physiology that can lead to a venous leg ulcer, which can really help us in explaining and educating our patients or carers that are helping us to look after these people with venous leg ulcers. And explaining the principles of the management of venous leg ulcers. And that's really, again, key to be able to do to help our patients understand the importance of management of their venous leg ulcers and management prevention strategies to stop these venous leg ulcers from reoccurring. So we're going to start by looking at some of the impact that venous leg ulcers can have. And actually, what we need to do before that is look at the definition of a leg ulcer. So a chronic leg ulcer is defined as a defect in the skin below the level of the knee, and that's persisting for more than 2 weeks and showing no tendency of healing after 3 months of appropriate treatment, or no complete closure after 12 months. So you'll find that statement in the best practice statement, which was released by Wounds UK in 2019. If you want to go and have a look for any further information, that's a really good place to start. So really what we need to remember is that if a wound on the lower limb persists for longer than 2 weeks, we need to be treating it as a leg ulcer. Now, I know previously it has been looked at that anything that's on the lower limb for more than 6 weeks, and we would be treating it as a leg ulcer. But we are now saying this 2-week period, so we really need to keep that in mind. The sooner we can start the treatment, the better. So a study in 2015 showed that there were 730,000 patients with a leg ulcer in the UK. And that really means and works out at about 1.5% of the adult population having a leg ulcer. Now that's quite a substantial amount of people that are suffering with these ulcers. And actually, do they always need to be suffering with them? Can we prevent them from happening in the first place by noticing the really early indicators that somebody has a venous insufficiency before they develop an ulcer? And I think we probably can, but we need to really educate ourselves as well as others to notice those signs and symptoms, and we'll touch on those a bit later on. But it's well recognised that ulcers occur because of this underlying venous disease. We really need to, as I say, recognise those very early signs and symptoms in order to prevent any further damage. So the number of diagnosed venous leg ulcers would indicate that actually 1 in 170 adults have a venous leg ulcer. So it's something that as a nurse, we're definitely likely to see at some point in our career. And I would be surprised if there's any of you watching today that haven't come across a venous leg ulcer and haven't had challenges around the management of venous leg ulcers. The financial cost associated with venous leg ulcers is phenomenal. And actually, you can see on the screen here, £1.94 billion spent on venous leg ulcers and the management and treatment of. So that's a huge, huge cost burden. And actually, we can be trying to reduce that as much as possible. There's a very high recurrence rate of venous leg ulcers. And actually, once those ulcers have healed, we need to be looking at how we prevent them from coming back and not reoccurring. So in a 12-month period, between 26 and 69% of leg ulcers reoccur. So that's again a 70% reoccurrence in patients that are not fitted with compression hosiery or that decide not to continue to wear their compression hosiery. And that can come back to the education that we give patients. And actually, they might not be aware that they need to continue to wear that compression hosiery. So we need to be able to have them really on board with their journey in healing their venous leg ulcer in order to then help them understand the importance of the compression hosiery moving forward. So you may or may not be aware of Betty's story. And this was looking at a suboptimal pathway. So a poor assessment to start with, and then unidentified etiology of an ulcer, which led to then compression not being started, so a delay in treatment, which resulted in longer healing times of more than 2 years before the wound was healed. With an optimal pathway and a really thorough assessment, including an ABPI assessment, we can establish and get early intervention in place with compression hosiery or therapy of some sort. And that leads then to optimal healing of less than 6 weeks. Because of the importance of the compression, if we can keep that in place, maybe reducing the strength of compression just slightly, we can try and prevent the reoccurrence. So 2 very separate pathways and 2 very different outcomes. You can see with the optimal pathway that actually the treatment costs would have been reduced. The impact on the patient's life would also have been reduced. And that's what we need to be aiming for, is that optimal pathway approach. So the impact that venous leg ulcers can have on a patient is also quite significant. Now, I don't know about you, but I know if I were living with a venous leg ulcer, I'd be concerned, and I would probably be experiencing some pain. I'd be concerned that actually there might be a risk of infection. The potential financial burden on the patient as well, from simple things like having to wash clothing and bed sheets and things more often if you've got a leaking ulcer, for example. So all of these things that we need to take into account. The person as well may not want to go out. They may want to remain at home because they may be embarrassed about their ulcer. I've seen it a number of times in my practice where people are reluctant to go out anywhere other than to see their nurse. Because maybe of the odour of the wound, or the fact that they just have to have a bandage on. So we need to take into account the impact that these leg ulcers have on patients. So we'll now go into a bit more depth on the underlying pathology of the venous leg ulcer. Some of the more common causes, let's start there. So when we're talking about common causes, it could be that actually we have a skin tear, for example, on a lower limb of somebody who actually has an underlying venous disease. So with all leg ulcers, there will be some sort of underlying disease, whether that's venous, arterial, mixed etiology, or a traumatic event which has led to the development of an ulcer. Some of the less common things we see are things like pyoderma gangrenosum, an infection from a tropical ulcer or an insect bite, for example, self-induced injury, or malignancy. So again, less common, but we do see these sorts of things in practice from time to time. Most commonly, leg ulcers are associated with that circulatory disorder, whether that's venous or arterial, or a mix of both. And they will account for 90 to 95% of all leg ulcers. But it's really important for us to get down to the bottom of the root cause of an ulcer so that we can establish the best way to try and help this person and get this ulcer healed. So we need to go back to thinking about our circulatory system and the blood flow to the lower limb. So we need to think about what that circulatory system actually does for us. And it supplies the lower limb with oxygen, nutrients, heat, medications potentially, antibodies. So we need to think about what it's taking down to our lower limb, and actually, if there's a restriction with that, then we could have a problem. Likewise, we will likely develop the problem if we have a venous return insufficiency. So when we're looking at the venous blood movement, we need to also think about the valves within the veins and our calf muscle pump, which supports that venous return. And you can see here on the diagram that you've got that blood flow through the vein, but you've got those little blocks within that vein almost. So those valves within the vein, helping to support that return. So that works in conjunction with our calf muscle as our natural pump. So we have this constricting and relaxing because of the muscle, and that helps to push and support that return blood flow back to the heart. Now, I've always used the analogy of a lock gate or canal gate with this, where one chamber fills and then releases and pushes forward to the next chamber. So that might help you with just thinking about how that works and how that structure works within our veins and venous return. So the causes of some of that calf muscle failure, and if we have that calf muscle failure, that's going to impact on our venous return. So if we have muscle weakness or paralysis, a fixed ankle joint because of arthritis, if we're obese, then we're going to be putting more strain on that calf muscle pump. If we're immobile, then we're not going to be using that muscle. So we're not going to get that natural support pump working. It may be that somebody has a congenital absence of the valves within the veins, causing that backflow. Multiple pregnancies and the weight of the baby can have an impact on our lower limb structures, and in turn that can affect our venous return and our pump muscle back, and then genetic factors. So all things that we need to take into account as part of our assessment of patient when we're looking at venous leg ulcers. So the development of venous disease, you may notice some subtle changes within the skin, which can be indicators for an ineffective venous blood return, resulting in that backflow that I spoke about previously. So the ineffective venous return leads to the backflow, which creates the venous hypertension. And with that comes the buildup of edema in the lower limb. And you can start to see the venous disease and skin changes subtly on the lower limb. This is before any development of a venous leg ulcer. So you might notice those early and subtle signs, such as ankle flare, varicose veins, that staining and pigmentation, edema, maybe some eczema presence, and atrophy blanch. And again, if you want any more details on all of those things, you should be able to find them online or within Wounds UK potentially. So the lymphatic circulation also has an impact, and we need to look at the lymphatic circulation and the role of removing fluid and waste products. So within that, we have our lymph nodes and lymph vessels. And actually 90% of our venous circulation is managed and helps to move the return blood flow to the heart and helps to reduce the risk of edema because of our natural pump. We then need to think about this 10%, which is the lymphatic system, which helps to support that circulation moving and the removal of excess fluid and waste product. So how can that impact venous leg ulcers? Well, the lymphoedematous changes can occur and swelling can occur, and they don't resolve with elevation overnight, putting more pressure on those lower limb structures. You could have some thickening of the skin and subcutaneous tissues, a distorted shape of the lower limb, or some hyperkeratosis, so those big, thick, dry plaques of skin developing. Chronic edema and lymphedema is quite common with people who have lower limb ulceration. And really the clinician who is making that first assessment should be able to have the ability to diagnose if there is an underlying lymphedema problem and come up with a plan and a treatment plan and solution to help support this patient. If they're not able to do that themselves and they're concerned that there is a problem, then you should be referring to a specialist lymphedema service or getting input from your tissue viability nurses if you're unsure yourselves how to do that. Assessment is really key in identifying and diagnosing any problem, and it's the paramount part of a pathway. Without thorough assessment, we're likely to mismanage or misjudge the treatment for this patient. So assessment really is key when it comes to lower limb wounds. So some of the potential causes of venous leg ulcers. A lot of them do start off as a traumatic injury of some sort, but with this traumatic injury, we then start to establish that there's already an underlying venous insufficiency. And actually, there might be occasion where we can intervene early with compression before a leg ulceration, but quite often patients don't present to us until they have a problem, and that could be that they've knocked their leg on a wheelchair or they've fallen and have a skin tear. The traumatic wounds with no underlying venous disease normally heal quite quickly. If they have an underlying disease, then they're likely to require that vascular assessment and compression if they're suitable for compression after their vascular assessment. So again, it comes back to the assessment of somebody being absolutely key and looking at all aspects of the assessment, not just recording an ABPI number. So signs and symptoms of arterial disease, just so that we can be clear on whether we're thinking somebody might have a venous leg ulcer or an arterial leg ulcer. So with arterial disease, we would be looking for things like intermittent claudication. We'd be talking to our patient and seeing if they have any pain during the night, for example, if they're having to hang their legs out of the bed, if their extremities, their toes, their feet are very cold or discoloured. When they elevate their legs, are they in significant pain, whether that's during the day or at night? Can we feel the pulses in their feet? Do they have any hair on their legs, or are their legs completely hairless, pale and shiny? All of these things can be signs of arterial disease. We may notice thickened toenails as well as being another sign potentially of arterial disease. So the positioning, if somebody does have an ulcer, where's the position of that ulcer? Where's it sitting on their body? We're more likely to see arterial ulcers below the malleolus. On the dorsum of the foot, quite common areas to see arterial ulcers. There's normally quite a lot of slough or necrosis present in these ulcers as well. They could be quite deep in comparison to, say, a venous ulcer, which is normally found within the gaiter area and quite shallow. So all things to bear in mind when we're starting to assess our patient and look at our ulcer. And before we've even completed our Doppler ABPI assessment, we can start to build up a picture of whether somebody is likely to be experiencing a venous or an arterial ulcer. So these ulcers with the underlying arterial disease have quite a significant medical history usually. They may have experienced cardiovascular problems, they may have had a heart attack in the past, they may suffer from angina. So taking a history from a patient is really key. There are certain risk factors which predispose somebody to the development of an arterial ulcer, and they could be medications, medical conditions and hypertension, diabetes, rheumatoid arthritis. It could be a hormonal issue. Lifestyle and lifestyle choices. Are they obese? Are they physically fit? Or do they have periods of complete inactivity? Stress is a contributing factor, and high cholesterol, smoking. So all things that we need to take into account as part of our holistic assessment of somebody. When we think about the mixed etiology of ulcers, we're going to be thinking about the most common signs of venous symptoms and arterial, and a combination of both of those. So the venous signs I have already mentioned, so ankle flare, edema, that's staining to the leg, the ulcer being within the gaiter area usually, hyperkeratosis or varicose veins. Arterial signs, intermittent claudication, no hair on the legs, the shining skin, delayed capillary refill, cold feet, or the colour draining from somebody's feet when they're elevated. Signs of arterial disease. So if you're seeing a combination of all of these things, or some from each of the lists, then it's likely that you have a mixed etiology ulcer. So it's really important that we're then thoroughly assessing that patient and seeing if they're still suitable for some level of compression, and you may need some guidance around that from your specialist nurses. So we'll now move on to some of the principles and types of compression therapy and our skincare regimes, and how they can support us with managing these patients with venous leg ulcers. So we want to start to treat the underlying cause, and actually treatment will vary depending on the type of the ulcer that we see. So we are going to focus around the venous insufficiency and treating venous leg ulcers today. However, if we were to note an arterial ulcer, then actually the underlying treatment for that would be arterial flow improvement. So it's likely to need a referral to a vascular team for further input to see if somebody is suitable for some surgery. We need to manage somebody's comorbidities. So, for example, if they're diabetic, we need to manage their glycemic control, which will also in turn help with healing wounds. If there's a venous insufficiency, we need to support that return blood flow to the heart, and that's why we choose to use compression. So appropriate referral to specialist is key. As I've mentioned, you may need a vascular surgeon if you're thinking that somebody has an arterial concern. You may need diabetes specialists involved if somebody has diabetes, or dermatology if there's an underlying skin condition, or varicose eczema. If you're not confident in dealing with that yourself, you may well need dermatology input. The reason we use compression, as I've mentioned, is to support that venous return to the heart. And actually, Laplaces Law is the underpinning principles behind our graduated compression therapy. So it's essential that we're doing this to support that venous return. And what we really need to do is create the correct limb shape for starters, and the compression should be graduated. So the strongest point should be just above the malleolus, reducing in pressure up to below the knee. So we're encouraging the correct movement of fluid and venous return back to the heart. And that's why it's so important that we have a smaller ankle circumference than we do around the area underneath the knee, to create that optimal shape in a leg, to create the optimal return back to the heart. So you can see that Laplace's law in practice, there's a diagram here which shows the smaller ankle circumference and that's slightly larger area circumference below the knee. And we've got that perfect return shape. So the tension of the bandage should be multiplied by the number of layers, which is then divided by the circumference of the limb and multiplied by the bandage width. So that's done for us in a lot of our compression systems. And what we need to remember as clinicians applying this is that we have to have the correct limb shape in order to get the correct return blood flow and to be able to facilitate that. So our graduated compression bandage, it's intended to apply a measured pressure at the ankle, as I've mentioned, with the pressure reduced by half, so 50% at the knee. That will give us that graduated compression, the necessary compression, to try and reverse that venous hypertension which we've spoken about. So to support those valves within those veins and those structures to return that blood flow towards the heart and reduce any excess edema. If these bandages are applied in the wrong way and they act as an external force in an area that isn't sufficiently padded out or protected, then it can cause pressure damage. And you can see that in the image here. And actually we have some bone exposure in the image here. And this can happen quite quickly. So it's essential that we recognise the risks associated with applying bandage systems. But it's also essential that we're only applying those bandage systems to people that are appropriate for the use of these. So we wouldn't be wanting to apply bandage systems, these compression systems, to somebody with arterial disease, because we're going to further compromise their arterial blood flow down to that lower limb. The person applying this should be skilled and have been taught bandage techniques, and they should be signed off as being competent to apply these bandages. So if you haven't yet done that, this session today doesn't mean that you will be able to go and apply those. It just means that you know the underlying principles to the way that we manage and treat venous leg ulcers. So early intervention is key, and this is why we look at that 2-week mark of having a wound on a lower limb and being able to treat it appropriately. We've seen within the Betty story and the different pathways the difference that optimal and suboptimal treatment can give. So immediate treatment of a lower limb wound with compression, particularly with those patients who have signs already of a venous disease, is key. And we really need to be acting quickly in order to prevent the ongoing problems that may occur if we're not optimally managing that person. That in turn will reduce the burden not only to the patient, but also to the healthcare service who are providing that care for that patient, and ultimately the cost to the NHS. Compression options. Now, we have a whole multitude of things available to us. We have the multi-layer elastic systems, bandages. We have compression wraps. We have hosiery kits and full ulcer kits, giving different levels of compression. And then we have the multi-layer inelastic bandage systems. So they all give compression, and they can all give up to that 40 millimeters of mercury of pressure that is the optimal level of pressure for healing a leg ulcer. But it just means that we need to be skilled in identifying which system is best for our patient. And actually, that's where we really need to be getting our patient on board with the decisions around their care. Based on our assessment, we can help guide them into what we think might be best for them. But we need to be involving our patients in those discussions from the outset. Compression hosiery. We need to be providing people with education around why they're wearing compression hosiery, the correct application method. We might need to provide them with some applicator aids in order to get their compression hosiery on and off. I don't know about you, but I know that I have struggled in the past to get compression onto somebody, and it can be tricky at times. So if a patient has dexterity problems with their hands, then it might be really challenging. And that might be the reason why they stop wearing their compression hosiery, resulting in extended healing times and a further impact to them as a person. So we need to be making sure that we're assessing somebody appropriately, and if we are selecting compression hosiery for this person, that they're able to put it on and take it off themselves, that they're able to complete their skincare regime and remove and replace these stockings. We need to give some guidance around exercise and leg elevation and which they should be doing. Weight management and diet also play a huge part in this. So a whole multitude of things that we need to consider when we're looking at compression hosiery. The fitting of hosiery is essential. We want to make sure that we're checking the measurements and that we have accurate measurements, that we're selecting the right size hosiery for patient safety and their compliance. And it should be done with their involvement. Again, from the outset, we need to get our patients on board with this and get them involved in their care as much as possible. A patient is more likely to comply and to continue to use compression hosiery if they fit correctly and if the person can see the benefit of wearing it. So we want to make sure that it's not too long and they're not having to fold it down or roll it down, as I've seen in the past, because that in itself can cause damage. We want to make sure it's not too tight and too short and therefore digging in to the lower limb and in some way, again causing more risk of pressure damage and problem. We don't want overcrowding of toes, and again that's something that can quite commonly happen if we have a sizing too small. So make sure you're taking all of those measurements accurately based on the product that you're going to prescribe. So important points to consider with compression hosiery is that the holistic assessment must have been undertaken, and we need to have assessed somebody's ABPI result and make sure that they are appropriate for the level of compression that we're selecting for this person. Again, that 40 millimeters of mercury of pressure is the ideal, is the optimum if we're looking at healing a leg ulcer, but we may do a step down to half of that, so 20 millimeters of mercury of pressure, for example, if we are looking to just maintain an already healed ulcer. So that step down approach. But we need to take into account each patient as an individual and complete that holistic assessment and regular reassessment. We need to exclude any arterial disease so that we know that we're not going to cause any further arterial compromise. And we need to check the person's overall skin integrity. Will the compression hosiery cause a problem? And trauma wounds, for example, if their skin is very thin and fragile. Consider open toe hosiery for somebody if they like to have their toes exposed. Is that an option for them? Is that something that we can support them with? And making sure that we're taking the correct measurements based on the guidance from the manufacturer of whichever compression hosiery you're looking to provide this patient with. We must be examining our legs for any deformities. we've already spoken about the importance of correct limb shaping. So if we have a limb that's very misshaped, then we're not necessarily going to be able to suggest compression hosiery for this person. So we need to take that into account as part of our assessment. Skincare. We also need to look at our skincare regimes. And in the presence of that venous hypertension, the skin does lose its natural oils and becomes very, very dry. You might have noticed when you remove somebody's compression hosiery or bandaging that you get that very dry, sort of dandruffy type appearance almost, with all these flakes suddenly falling off. Well, actually, that's quite common with leg ulcer management. And we're also restricting that natural shed of any skin by having somebody in bandages or compression hosiery. So we need to make sure that we're staying on top of that. And these people do need regular washing of their limbs and possibly emollients to support that skin, because, as I say, they've got that natural oil loss because of the venous hypertension. So a good skincare regime and management regime also helps to reduce the risk of infection, because you're not getting that very dry, cracked skin. You're keeping it nice and supple with the use of emollients. It means that there's less risk and less likelihood of skin breakage and therefore route in for infection. So all things that we need to consider. What does the patient wash their legs with? Is it appropriate, and is the pH balance appropriate for their skin type? So again, something to consider. So when we look at moisturisers and understanding our moisturisers, an emollient is the key ingredient of moisturisers, and that really does replace the lipid or the oils that helps to seal the skin and prevent that surface breakage or water loss. And it's important that we're using the appropriate moisturisers and emollients to support our patients. Sometimes if they contain preservatives, that can act as an irritant. So we just need to be aware of that when we're looking at which moisturisers somebody is using. They come in a whole range of different preparations, so ointments, creams and lotions, and all of them work in slightly different ways to help support our patients. So you need to be selecting something that's appropriate for that individual that you're assessing. Applying emollients. Now you might think, oh, we've applied emollients and moisturising creams for years and never had a problem. Well, that might be because you're naturally doing that in an appropriate way. But if you haven't had any education on how to apply emollients, really what we should be doing is applying them in gentle downward strokes in the same direction as the hair follicles and the hair growth. If we don't do that, then we run the risk of clogging that hair follicle, which leads to the inflammation and folliculitis, so infected and inflamed hair follicles. So we want to try and prevent that as much as possible. How can we empower our patients with all of these things that we might be seeing and this ulcer on their leg? How do we empower them? Education. It's key. We really need to be explaining to them the underlying cause and what's happening with their lower limb and their venous disease and some of the treatment options available to them. We want them to be involved and feel like they have a choice in their care. And I know, for example, if I were to have a venous leg ulcer, I wouldn't want multiple layers of bandaging on. I'd much prefer to be managing my leg ulcer with compression hosiery or a wrap. But again, that's my personal choice. Your patient may prefer a bandage, but having those discussions with them and getting them involved in their care and treatment does help to try and motivate and empower them. The compliance with their treatment is key. We need them to be able to comply with their treatment. And really, if we give them the option and include them with the decisions around their care, they're more likely to be compliant with that. So we'll now go on and have a look at the actual assessment and how we can simplify the approach to assessment and wound assessment. So in this instance, we're looking at the triangle of wound assessment. It's a holistic framework. It takes into account the patient as a whole, their social circumstances, and it helps to support you as clinicians to make decisions around the three key aspects of the wound itself, and that being the wound bed, the wound edge, and the peri-wound skin. So some of the benefits of using this is that actually it's really easy to use. It facilitates our documentation really well, and it provides that potential improved continuity of care. Everything is so clearly documented on here that actually it doesn't matter if it's not the same clinician going back and seeing this person at each dressing change, because we should be able to identify what the wound bed, wound edge, and peri-wound skin were like at the previous dressing change, and see quite clearly how that's moved on, hopefully in a positive way. But if it has deteriorated, we should be able to identify that because of the really clear and thorough documentation and simplified approach to this assessment. So things to consider that happen, behind that wound, and whether we've really assessed our patient as a whole, or whether we're just looking at the wound. We do need this to be a holistic approach. So we need to take into account any malnutrition, any reduced blood supply or arterial disease potential. Likewise, any venous return insufficiencies. Medications. Has this person undergone radiotherapy or chemotherapy? Are they obese? What is their BMI? Are they getting appropriate nutrition? What's their overall circulation like? Their psychological status. We know that that can have an impact on wounds and wound healing. Do they have any infection? Is there an underlying disease, diabetes, for example, that needs to be managed? Do we have maceration to the actual wound itself? Or poor wound management? Do we have some excoriation? Do we have deterioration because the fluid and exudate in the wound isn't being managed sufficiently? Is it a link with pressure? And do we need some unrelieved pressure ulcers, for example? So we need to take into account absolutely everything to do with this person, not just look at the wound itself. And in the instance of venous leg ulcers, we also then need to undertake a venous leg ulcer assessment, so a vascular assessment, and as part of that, an ABPI assessment. What does a wound need? Well, that's going to vary from person to person, and our objective for each person's wound will differ slightly based on what we're seeing. But at the heart of all of that is our holistic assessment. We then, if it's on a lower limb, should be completing a vascular assessment and our specific wound and skin assessment as well. So 3 branches of assessment really are overall holistic, vascular assessment, and then really focusing in on our wound and skin. We need to take into account any environmental factors. So is the person living in a clean environment, or are we trying to manage and change this wound in a suboptimal environment? In which case, can we improve that? Could we bring them into a clinic or into a surgery for their dressing change, for example? Are we documenting everything that we're doing and everything that we're seeing? Are we taking photographs if we're able to do that and have consent to do that? That helps us to really monitor wounds and monitor the progress or deterioration of a wound. Are we evaluating and re-evaluating our management plan? All things that we should be doing as part of our wound management and assessment. That then brings us on to wound management options. And actually, your option for your primary dressing will differ. And it depends on the secondary treatment. So which type of compression is somebody having with a venous leg ulcer? Do they have fragile surrounding skin? Are we concerned about deterioration? Is the wound infected? So what we really need, the basics for a wound dressing to do, is to absorb any excess exudate and reduce any risk of exudate pooling, maceration and leakage, which can lead to a whole cascade of challenges in itself. We need to maintain the humidity of the wound, so we need that moist wound healing environment. We don't want it to be too dry. We need to allow a gaseous exchange to occur in order to create that optimum healing environment. We want to reduce any risk of infection, so we want something that's going to conform to the wound bed itself, preventing any exudate pooling, which in turn can lead to an increased risk of infection. We want something that's going to protect the wound from very low temperatures, because if a wound drops its temperature significantly, then it's not going to be in an optimal position for healing. So we need to be thinking along the lines of appropriate dressing selection as our primary dressing. That may be, for example, a foam silicone dressing underneath compression hosiery or a wrap, something that a patient may be able to help self-manage and change in between their visits to you as a clinician. Or it could be that we're using a conforming foam dressing that would meet the wound bed and prevent any exudate pooling and leakage underneath a compression bandage, and we may want that to be a non-silicone foam. So there are different options available to us based on what we're seeing. Pathways are also a really important part of our care, and it can mean that it just gives us those prompts that we may need in the very busy times that we all experience to just help us to manage patients effectively. And that this is an example pathway, but it takes into account whether the patient does have signs and symptoms of arterial disease, and if they do, what do we need to do about that? And actually this would then guide you to refer them to a specialist for further assessment to see whether we can improve that arterial circulation, which in turn would then help to heal an arterial ulcer. And in the meantime, whilst we were waiting for that assessment, we would look at an appropriate dressing selection for that wound based on the actual wound itself. If a person doesn't have signs of arterial disease, then we would go on to complete a really thorough ABPI assessment, which would then give us an ABPI number range. And we would then see whether somebody is suitable for what we call full compression, and that 40 millimeters of mercury of pressure, which would create that optimal venous return support. Or are they not suitable for a full compression? Do their ABPIs not allow for that? And actually, do we then need to be considering managing them with a different level of compression based on assessment and appropriate selection? And if you're not happy with deciding that yourself and aren't experienced enough to be able to make that decision, then you would need to refer on or get guidance from somebody who is able to support you with that. We then need to be reassessing this and actually thinking to ourselves, is this wound improving? With everything that we've done so far, is the wound improving? If it is, then great, and we can carry on with our current care. If it's not, we need to go back to the very beginning and reassess and reevaluate our patient and really get to the bottom of the delay of the healing and think about what we can do to overcome those challenges. We might need to reassess for compression hosiery or compression therapy overall. This is where we may need that specialist referral to come in if we're not getting on top of this wound ourselves. So I'm hoping that you found some of this really useful today. But in summary, leg ulcers are quite common. 30% of venous leg ulcer sufferers do develop a leg ulcer before the age of 50. Now, I'm below the age of 50 and I would definitely worry if I were to develop a leg ulcer, but it does happen. And actually, as nurses, we can try and help prevent that from happening to people by picking up on those really early signs of venous disease and venous insufficiency. We need to be thinking and looking at the importance of our assessments and really establishing the underlying etiology of a wound. That will help us with our treatment and management plan. 90 to 95% of all leg ulcers are arterial, venous or mixed etiology. So again, we know from today's session that if it were a venous leg ulcer, we would try and manage that wound with compression therapy. If it's arterial, we would be looking at referring that person on to a specialist service, a vascular service, for further assessment. And if it were mixed etiology, we would then look at how that person is best managed and weighing up the risk versus benefit of whether they might be suitable for some level of compression. We want the treatment to be aimed at correcting the underlying cause. Whatever the cause of the ulcer, whether it's arterial or venous, we want the treatment to be aimed at correcting the insufficiency. Non-concordance is a significant problem and actually affects 22 to 25% of the people we try to manage. And we know with non-concordance, we're more likely to see reoccurrence, and that's why those reoccurrence rates are so high. So if we can get somebody on board with their treatment and get them to understand the significance of the problem and how we can best support the management, they're more likely to be compliant with their treatment. Also, give them choice. You know, none of us like being dictated to, and we need to remember that when we're discussing the options with our patient. And we do need to be giving them options, finding something that's suitable for them. It's all very well us putting somebody into a compression system, but that compression system is only going to work for that person if they keep it on. And I know that I've had challenges with people in the past where I've tried multiple different bandages. We've tried different wrap systems. We've tried different compression hosiery kits. But eventually you will get there and find something suitable. But the key is really identifying with your patient and finding out what their concerns are around these treatments and what they feel would be the best option for them. So I'm hoping that you've taken something from today and that it will help you with your management of patients with venous leg ulcers moving forward. Please feel free to reach out to any of the Coloplast representatives for any further information if you require it. And we welcome you to any of our future sessions. Thanks for joining us.